The broadcast is now starting. All attendees are in listen-only mode.
Good evening once again, everybody. Welcome to tonight's absolute neurological extravaganza, sort of your tonight with the central nervous system. I'm Jeff Downing, your guest tonight. Absolutely thrilled to be guiding you through the twisted labyrinth of axons, dendrites, and mysterious lesions that make neurologists speak in coordinates like they're playing some deranged game of cerebral battleship. Now, look, I know that for many of you, neuro can feel about as accessible as a cat's inner thoughts or the appeal of accordion music. But here's the thing: the average adult brain contains roughly 86 billion neurons. And tonight we're going to focus on the approximately 7 that you're going to need to answer these board questions correctly. So, you know, obviously nothing really says I'm ready to be a doctor quite like being able to distinguish between a lesion in the medial medulla versus the lateral pons. And, this is information that I promise will be simultaneously critically important and frustratingly difficult to recall in the middle of your exam. So we're excited to be here, and I'm delighted, of course, to be joined by Dr. Abraham Titus, Hematology and Oncology Fellow at the University of South Alabama. Abraham, would you like to introduce yourself to our audience of sleep-deprived students?
Sure. Well, it was a pleasure to meet you guys all. My name is Dr. Abraham Titus. I'm, like Jeff said, a hematology oncology fellow at the University of South Alabama. I've been a tutor with USMLE-Rx for quite a few years now, and I've helped many students such as yourself through their step 1, step 2, and even step 3. So I'm excited to be here and kind of tackle some neurology. Again, one of those topics that lots of high yield things from there and a lot of things that are easily forgettable. So I think just kind of focus on the high yield stuff within neurology. It can be overwhelming, but let's kind of get what's most clinical, what's most important, what's most testable. And that's kind of what I included in our questions lab today.
Very good. And that's great. And, I've already got a student who says that they're already freaking out. Let's not freak out, everybody. Let's just breathe. Let's relax and let's focus on learning. But before we do that, I'm going to tell you, know a little bit about us, and we would like to learn just a little bit about who's out in the crowd tonight. So I am going to launch the first poll, and this is your gimme. This is the easiest question you're going to get tonight. Who are you? So we use the quick poll feature here in GoToWebinar. And once you have mastered this is the only tech that you're going to have to worry about tonight. Otherwise, you can just focus on listening, learning, and answering the questions as they come up. Usually once we hit the 75% answered threshold, then I close the poll and share the results. Okay, so we're getting there. Let's see, about 60% of you voted. Go ahead and let us know in M1, M2, M3, M4, or are you an IMG or FMG? Okay, let us go ahead, and I think we're close enough. I want to move a little quicker tonight. I know that, some folks may have things going on, so I want to get straight into the questions here. So I'm going to close the poll and let's share the results. So looks like we've got a strong contingent of IMGs and FMGs, almost 60%. And we've got a quarter of you that are M2s. Perhaps you're in dedicated right now. Perhaps you are, looking down the barrel at step 1. Also got some, some M3s here. We've got some M1s kind of getting a lay of the land. Also some M4s. So that's great. A great mix. We're really happy everybody is here. Now, should ask, how many people have been to Question Lab before. I do see some familiar names, but if you haven't, if this is your first time, or if it's been a while, we here at ScholarRx and USMLE are really focused on preparing students so that they, perform well in med school, that they learn all the basics, that they understand all those core concepts that they're going to need on the floor, and that we also help make sure that you're ready on test day. And that might be for a block exam, that might be for, CBSSAs, or it could be for step 1 or step 2. And as a part of what we do, we've started our, this question lab, which we've now been doing this for just over 5 years. We started this just, back in the spring of 2020. So we've been doing this a while. And as a part of what we do, we really focus on not only the content, not only the knowledge that you're going to need to answer these questions, but also the technique, the methodology, so that, as you learn how to slice and dice these questions, you also have, a really, a good approach. Now, our approach is a suggested approach. This is one that's, that we've used for a long time. And in fact, Abraham and other of our coaches have used this. But the main thing is, knowing, you've got a, kind of a regimented approach to each question so that you can kind of answer it, just like a test taking machine, right? So we're going to be showing that as we go through tonight's questions. So we're going to start with question number 1. I am going to warn you that, we do question lab a lot. Sometimes we mix up the difficulty. These may be difficult questions. I'm not going to, I don't want to sugarcoat it. So the key thing though is, really kind of focus on the, how you go about it, and really kind of pay attention to the cues that, that Abraham shares. So the first thing that we do when we start a question is we cover up the answer choices. And the reason we do that is we don't want you to get distracted by, perhaps a condition or a diagnosis you don't know much about, or, something that's confused you. We want you to take each question step by step. So we ask you to cover up the answer choices and then read the lead in. And the lead in is the actual question, right? So in this case, the lead in is, this patient's stroke most likely damaged which of the following brain structures? Okay. So, there are those who, just by, their own history of answering questions may start with the vignette, right? They may start with the scenario, but because the USMLE hits you with these long, clinical scenarios, reading that lead in first gives you a number of cues and a number of things that should help you understand what you're looking for and what kind of information is going to help you solve this, right? So we ask you, let's read the lead in, and then now that you know a little bit about what you're looking for, what you're trying to answer, now we can read the vignette. An 87-year-old right-handed woman is brought by her husband to the emergency room after she suddenly mispronounced multiple words. For example, she said, "We need to go shipping today," and "I think we are out of Lindry detergents," instead of laundry detergent. On examination, the patient's speech is fluent and demonstrates normal intonation and content, although when asked to identify knuckles, she said, "Nickels." She can follow complex 3-step commands such as close your eyes and touch both shoulders 2 times with 2 fingers. However, when asked to repeat individual words or the phrase, "no ifs, ands, or buts," she is unable to do so. So again, the question, this patient's stroke most likely damaged which of the following brain structures? Think about what brain structure, you would propose, what your hypothesis is, as I pass it over to Abraham.
All right. So exactly like Jeff said, you want to leave the lead in, you want to have an idea of what they're going to ask, and then go for the question. So let's go through, highlight some keywords here. We have a patient with some speech difficulty, right? And the way they describe the speech difficulty is important. What's the problem in the situation? So 87-year-old right-handed woman, right? So whenever you see neurology questions, they'll usually give you the right-handed versus left-handed. It's not super important, but it's kind of gives you a good idea of what's the dominant hemisphere. Now, suddenly mispronounce multiple words, right? So they have a pronunciation problem. They kind of give you some examples of it. Sure. Speech is fluent. That's very high yield to remember, right? It's not broken speech. Its speech is fluent and has normal annotation, normal content. So notice what's going on. Can follow commands, but the big problem is cannot repeat the phrase. No ifs, ands, or buts. So that's kind of the clue that they're trying to get at here. And they're trying to ask you, okay, what brain structure would be associated with this kind of problem, right? So there's a umbrella term we use for speech difficulty, and there's different types of speech difficulty. There's the two common ones that we often get tested on. There's one extra one, which is what I want you to also be aware of in this situation as well. Okay, so we'll talk about this in detail when we get to the answer options, but let's pop the options open and let's try to pick the best answer we think is right. Right. So again, like your typical USMLE question, about 5 options seems to be average here. Let's go from E all the way to A. I like to start with E just because, whenever the test writers write the question, I always feel that there's usually traps laid out for A, B, and C. So I want to kind of take that aspect out of it and just kind of go in blind. If I do have one that in mind before you got to the options and you see it, go for it. No questions asked. Well, let's start with D. Postcentral gyrus. Option D, superior temporal gyrus. Option C, medial longitudinal fasciculus. Option B, inferior frontal gyrus. And option A, arcuate fasciculus. Now, these are different parts of the brain. Your question is, which is most likely damaged in this patient who has fluent speech, clear connotation, can follow words, but has mispronounced words and has inability to repeat individual words or phrases? All right, take your time, and the options will be coming up shortly, and we can kind of pick an answer.
Okay, everybody, you've got your job to do here. Which of these brain structures was most likely damaged during that patient's stroke? Okay, let's see. Almost 80% of you have voted, so I'm going to close the poll and share the results. And let's see, a little over a third of you went with the arcuate fasciculus. About a quarter of you went to superior temporal gyrus, and about 1/5 of you went with the inferior frontal gyrus. So, and we got some votes for C and E. Okay, good mix. Let's go ahead and hide the results and share the answer. And the answer is answer choice A, arcuate fasciculus. Great job, everybody. Good way to start off Question Lab. Like I said, these, that's kind of a tough one here to, as our lead in, as our starter for tonight. But nice work. But if you didn't get it right, that's okay. We're here to learn, and Abraham's going to show us the way. So I'm going to let him walk through the explanation.
All right, great job, guys. Again, neuro is a difficult topic, especially when you're first coming in. And I did pick difficult questions, but these are all high yield concepts. And aphasia is a big one. So this, when someone has difficulty speaking, you got to think, okay, this is an aphasia. Now, when I think of aphasia, you got to categorize it in 3 categories, right? We always know the first 2, Broca's and Wernicke's, right? Those are, one is broken speech and one is wordy speech, right? So B for broken, W for wordy. So if the person can't get words out and they're like, when they're trying to repeat multiple words or have difficulty completing a clear sentence, that's Broca's aphasia. Wernicke is that they can complete sentence fluently, but it won't make any sense and they won't be able to follow commands. Neither of which is what's happening with this patient, right? Those are the 2 common that we learn about. But there's the third type of aphasia that's pretty high yield, and they love to test it because people always skip over it. It's called conduction aphasia. So conduction aphasia is a problem where this arcuate fasciculus connects my 2 Broca's and Wernicke's areas of the brain. When I don't have that proper connection, I can't repeat words. That's the key here. So the key here is that it's not a problem with speaking, like it's not a motor problem, which is the Broca's, which lies in the frontal cortex. It's not a problem with the Wernicke's, which lies in the temporal parietal cortex, in the dominant brain. But because she's fluent, so the Broca's is intact, and she has a normal understanding. So the Wernicke is intact. So they kind of clearly state that in the first part of this question. But the part that they really want to focus on is repetition, being able to hear something and repeat the sentence. So in order to do that, you need to understand it, and you need to have the Broca's ability to motorily say the word. So the connection between the two is messed up, and that's the arcuate fasciculus, which connects the two together. The other options here, inferior frontal gyrus, again, that is the Broca's aphasia, so that's being non-fluent speech. Medial longitudinal fascicula, so that's not the eyes, right? So that's a whole different topic here. That we're talking about multiple sclerosis. That's kind of getting into a different topic, in which most of you guys picked that one. Superior temporal gyrus, I think a lot of you guys picked that well. That's Wernicke's, and this person understands what's going on. Person can follow commands, has normal intonation and content. That's very important to understand. So they know what's going on. So that's why it's not the right answer. So again, with this one, the most important part of it to understand is you see the big picture in terms of, okay, the 3 aphasias, which one is this? There's also a 4th one called global aphasia, which is less tested, but that just means the entire system was gone. But your 3 ones should be Broca's for broken speech, Wernicke for wordy speech, where you don't know what's going on, but you just keep talking. And the 3rd one is conduction aphasia, which is a repetition, where everything else works, you just can't repeat words, and you mispronounce some words here and there. But great job, guys. If you didn't get this right, it's a good point to learn. Important to go over the aphasias before exam day.
Okay, Abraham, talking about pronunciations, is it gyrus or gyrus?
I think it depends on who you ask. I've always said the gyrus, but I think the gyrus works for some people as well. So I think one of those words.
Okay, yeah, Jamie, you're not in trouble on that one. So good, good. That's a perfect question for that particular QID. Okay, we're off to a good start, everybody. Let us move to question number 2. And here we've got an image, right? So, again, we've covered up all of those answer choices, and we're going to look at the lead-in. Which of the following additional abnormalities is most likely to be found in this patient? Okay, so just by looking at the lead-in, you know that, hey, I'm going to be learning about some issues that this patient's having, but then I'm going to have to think about, well, what else would they find? Okay, so you're already probably looking at the photo, so let's read the vignette. An 18-year-old man comes to the clinic because of bumps forming on his back, shoulders, and arms. Physical examination reveals a dozen small, bumpy prominences on his upper back and shoulders. They are non-tender, non-mobile, and firm. The physician also notices unusual freckling patterns in the patient's axilla and groin area, as well as areas of hyperpigmentation on his upper arms and lower back, as shown here in the photo. So, the question again, which of the following additional abnormalities is most likely to be found in this patient? Taking a look at that, taking a look at the vignette, what do you think?
All right, so let's break this down here. So I think this is a great question here that Jeff put up here. Take a look at the picture, take a look at the highlights here, and let's figure out what's going on, right? So this is an 18-year-old man, so young male. We want to think about the way they're describing it. So bumps forming in his back, shoulders, and arms. And it's happening all over the place. Non-tender, non-mobile, firm. But the freckling pattern is also seen. Okay. The axilla and the groin area. They give you some pigmentation here in the image, and they kind of want you to get a idea of what they're pointing at here. Even in the picture, you can see not only the hyperpigmentation, but you can also see the little freckling that's going on in the picture. So using the information mostly from the picture, but also using the clues that they give you here, you want to know what the diagnosis is and kind of get this diagnosis just based on this, right? This is very high yield syndrome. You need to know what it is right away. Now, the next step, what additional abnormalities am I about to see in this patient? So take your time, try to figure out what's going on. Let's look at the options here. All right. So again, I like to start with E, vestibular schwannoma. D, pigmented nodules of the iris. C, mutation of P53 gene on chromosome 17. B, mutation in the tumor suppressor gene on chromosome 22. And A, misproduction of the gene product Merlin. Now, options like this always used to trick me because, it's a lot of information here. Try to pick out kind of something that sticks out. If you know the diagnosis, it makes it a lot easier, right? Trying to work backwards in these situations isn't the best strategy. You want to be able to look at the picture, look at the story, look at the age, look at how the patient is presenting, come up with the diagnosis, number one. Then using that, getting to the answer makes it a lot easier. It makes it cleaner, as opposed to you don't fall for the traps. But take your time and really think about what this could be, and then what additional abnormality I'm about to see in this patient. It's not asking about what's happening in this guy. What additional findings can I find? Right? And Jeff brought up the question here. Yep.
Okay, everybody, let's fire away here. Okay, so a little over a third of you went with answer choice D, pigmented nodules on the iris, but also had quite a few votes for vestibular schwannomas and mutation of the P53 gene on chromosome 17. Also, a mutation of the tumor suppressor gene on chromosome 22. So, okay, there's nothing absolutely clear here. So this is good. So I'm going to hide the results and let's share the answer. And the answer is answer choice D, pigmented nodules on the iris. So great job, everybody. Again, these are tough questions. Quite a few of you got it right, but it doesn't matter. What's important is that you understand why it's the right answer. So, maybe you got it right by, a little bit of luck. So Abraham's going to shore this one up.
All right. Well, great job, guys. Again, another tricky one here. It's neurology. We expect some of these tricky questions. So I saw a few of you guys drop in the question box. What is the diagnosis? I want you guys to think about this one. Try to figure it out, right? So based on the cutaneous picture, right? So let's go back and look at the question. Let's figure out what is going on. So this kind of looks like if I mix coffee and milk together, right? It's that color of coffee and milk. These are what we call cafe au lait spots. It's a big French word, just means coffee and milk. So that's the color of the kind of spots you develop on your body. And these little nodules, like how you see all over the body, that are non-tender, non-mobile, and firm, are what we call neurofibromas. So this is a neurofibromatosis type 1 patient, NF1, right? So you're going to see these type 1. So remember, NF1 is the cutaneous one, right? I'm going to see, there's such a thing called NF2 as well, which I want to talk about. There's type 1 and type 2. If I see classic, like cutaneous features, think 1. If I hear them talk about hearing loss or anything, I think I have 2 years. So NF2 is the one that's associated with the one that most of you guys picked as the second most common answer, vestibular schwannomas. Vestibular schwannoma is a good trick option in this question, right? They want you to think neurofibromatosis, and that you always vestibular schwannoma is like the first thing that everybody jumps on, because that's such a classic feature of NF2. But that's more likely to present with hearing loss as opposed to skin findings, right? If it's a purely most of the skin findings are presenting with, I want you guys to think this is an NF1 situation, not an NF2 situation. If they were saying hearing loss is the main presentation, then vestibular schwannomas would be the correct answer. And that would kind of change the whole question completely. What about the other ones? Okay, tumor suppressor gene on chromosome 22 and misproduction of Merlin, they are both also pointing at NF2. So that 3 options pointing at NF2, that's the other clue that, hey, this is maybe not NF2, right? This is not maybe neurofibromatosis type 2, this is type 1. Because A, B, and E are all seen in neurofibromatosis type 2, where they'll kind of more likely present with skin finding. Oh yeah, with hearing loss, sorry, as opposed to skin findings. NF1, right, neurofibromatosis type 1, does have an additional feature, which is very important. And these leads to these pigmented nodules in the iris. And this is, if you look in your first day, you will see that classic picture. It looks like a doorknob that's kind of present in the eye. And they're called Lish nodules. They're pigmented nodules in the iris, very classic for neurofibromatosis type 1, also known as Lish nodules, Lisch. So if you see those terms anywhere, you know what they're talking about. They're talking about NF1. What about the other option? The one that, didn't really fit the rest. E53 on chromosome 17, that's Lee-Fermani syndrome, right? This guy, if he developed leukemia at age 13 and then developed colon cancer at age 25, if he has family history of cancers, that's Lee-Fermani syndrome. P53, I always want you to think high-risk cancer. These patients will develop cancer at such an early age, and multiple family members with cancer, that's what they'll point at. So option C is all about cancer. Option A, B, and E are neurofibromatosis type 2. And only option D really fits that neurofibromatosis type 1. And that's what they're really trying to get at with the cutaneous findings, with the picture, and with the clinical presentation of showing neurofibromas. Great job, guys.
Okay, nice work, everybody. We are halfway through tonight's event, so it's time for a stretch break. So get up from your desk or, get down to bed before we continue our journey through the neural superhighway. I just want to talk about why we're all here tonight. And no, it's not just because we collectively enjoy the feeling of medical inadequacy that comes with trying to remember cranial nerve pathways. If you find Question Lab helpful, and judging by some of that frantic note taking that I can almost hear through the screen, then you're definitely going to benefit from USMLE-Rx's comprehensive resources. Our QBank, QMax, has over 5,000 board style questions for step 1 and step 2. That includes extensive neurology section that'll have you drawing dermatome maps in your sleep. Our interactive bricks are these digital learning experiences that really break down these complex neuro pathways into digestible segments. We've got express videos, over 1,300. That's about 90 hours of video that offer visual explanations of concepts like, cerebellar circuits and basal ganglia that, let's face it, they really don't make a whole lot of sense when described in text alone. And then, obviously for those, 3-minute study sessions between rotations, the flash facts really help you remember the difference between things like, Weber and Rennie tests, which, hey, spoiler alert, these are going to appear in your boards in some form or another. So again, we're so happy to be able to bring this free event to you. Question Lab number 174. And, we definitely want you thinking about USMLE, because we want to make sure that we're providing things that are helpful for you and, your education and your future career. So head over to USMLE-Rx.com and get started. But don't get started yet. We've still got 2 more questions to go. And that means we're ready for question number 3. Remember, we do have a raffle at the end of tonight's session, and then we'll have a special coupon code too. Okay, so opening this one, you look at it. We've covered up those answer choices, but you can see, oh, you know what? Not a lot of text here, which means I'm probably going to have to understand what's happening in the CT scan. Okay, so A, we've covered up those answer choices. B, we need to read the lead-in. Which of the following is the most likely cause of this patient's pathology? Okay, so again, what do we have to do? We're going to have to figure out what that pathology is, and then we're going to have to figure out the most likely cause. So with that, now we're situated and we are ready for the vignette. A 60-year-old woman comes to the emergency department because of a sudden onset severe headache in right hemiparesis after an episode of emesis early this morning. She has a history of rheumatoid arthritis, hypertension, in hyperlipidemia. Urgent non-contrast CT scan of the head is shown. Now, so again, which of the following is the most likely cause of this patient's pathology? Take a look at that CT, come up with some answers of your own as I turn it over to Abraham.
All right. So we got a CT scan to deal with here. So we got a 60-year-old woman who presents with all these symptoms, right? So let's go through, let's highlight some keywords here, and let's try to figure out exactly what's going on with this patient. So again, lead-in is always the most important thing, most likely cause, right? So the pathology, you want to know what the cause is. Let's go through the question. 60-year-old woman. Okay. So little older woman, severe headache, right-sided hemiparesis. MSS history of rheumatoid arthritis, hypertension, hyperlipidemia, and then a non-contrast CT, right? It's important that they tell you that. It's important that you understand, is there contrast or non-contrast? And I'll explain that when we talk about the kind of explanation of everything, but you want to know what kind of CT we're looking at. And, they're not expecting you to be radiologist. Just look, there's an obvious, and they're pointing an arrow at it. So it's very obvious there's something going on, right? This is on the left side of the brain. Remember, CT scans are always flipped. So we're looking at the left side of the brain here with this little white thing that's going on there. And then it's leading to her right hemiparesis. So, it makes sense. It's flipped. Then we want to think about what's causing this. Look at where this white spot is in the brain. Think about what the presentation is. Think about the patient's history as we look at the options, and let's figure out what the answer could be here in this situation. All right, so let's start with E and make our way up. So option E, ruptured berry aneurysm. Option D, rupture of bridging veins. Option C, hypertension. Option B, glioblastoma multiforme. Option A, amyloid angiopathy. All right, so all these are good options. They're all neuro-related. They all can cause issues in the brain. But what is most likely in her situation that led to these right hemiparesis, led to everything else that's going on in this situation? So take your time and let's try to figure out what the answer could be.
Okay, so we're going to launch the poll. And you can tell us what you think is the most likely cause of this patient's pathology. 60-year-old woman. Okay, let's go ahead and close the poll and share the results. Okay, so it's interesting. The percentages here for each of the questions seem to be roughly the same, or at least in terms of the breakdown. So almost 40% of you went with hypertension. About a quarter of you went with ruptured berry aneurysms. And then we got some votes for rupture of the bridging veins. And then amyloid angiopathy and glioblastoma multiforme came in, kind of bringing up the rear. Okay, so very interesting. Let's go ahead and hide the results and reveal the answer. And you guys did it again. Answer choice C, hypertension. Well done. There's a lot that you have to be able to pick out in that question. You guys did a nice job. Of course, if you didn't get it right, that's fine. This is the time to get it wrong. When it all comes down to it, this is the time. Hey, we're all about learning. We're all about improving. So Abraham is going to walk us through it so that we don't get it wrong on test day.
All right. Well, great job, guys. Again, this is another question that's a neurology. You guys are 3 for 3. Good job. Now, first of all, I want to kind of talk about this CT scan here. That's the most important thing that kind of clues you in. There's not many things that they expect you to understand just based on the radiology, but they always give you the clues to kind of associate with it. So when I think non-contrast CT, I'm not putting IB contrast in the patient. Blood is always going to show up as white. So if I see a white spot on the brain on a non-contrast CT, could this be blood? If this is a contrast CT, it could be blood, it could be tumor, it could be anything else. When it's a non-contrast, think white equals blood. Okay, so let's we got that down to begin with. That's very important to understand, just based on the density of the tissue and how we kind of interpret this. So, and look at where this white spot is, right? It's in the actual brain tissue itself. It's not on the edges of the brain. It's not in the middle. It's not in the ventricles. It's in the brain. This is what we call an intraparenchymal hemorrhage. So he had, or she had, a stroke, right? She has history of hypertension with sudden headache and weakness and vomiting, right? So that kind of fits with this idea of the sudden onset of everything. This fits with the stroke. This is a hemorrhagic stroke. And as we know, we should know, the most common cause of hemorrhagic stroke is hypertension. No question about that. It's always the blood pressure that causes stroke, right? So let's say, hey, my blood pressure is too high, I'm going to get a stroke. That's the big concern about it. This is a spontaneous, or AKA non-traumatic, intraparenchymal hemorrhage, most likely secondary to hypertension. Okay, this happens not secondary to my berry aneurysm rupturing. This happens to a different thing called Charcot-Bouchard microaneurysms. Okay, it's a big fancy word, but it's a guy's name. But that's not the most important part. The most important part is that you understand you're having microaneurysms form in the blood vessels that go into the parenchyma. We call this lenticulostriate arteries. And these can then rupture, and then you can bleed into the brain. Looking at location is very important in the situation. Looking at the history is very important here. And also commonality, right? If someone is going to get a hemorrhagic stroke intraparenchymally, think, hey, this is a Charcot-Bouchard aneurysm that ruptured, led to an intraparenchymal hemorrhage, secondary to hypertension. Let's look at the other options here. Middle meningeal artery rupture, right? That's your epidural hematoma. That's the guy who's climbing the ladder, getting on top of a building, fell off, hit his head. Had this lucid interval where he kind of was awake, but it was kind of out of it. And then he's like about to die. That's your middle meningeal artery. Middle meningeal artery, think about this is a patient that climbs something and falls. What about bridging veins? Bridging veins is another high one that has a lot. This is my subdural hematoma. These are the patients who are a little older, got into a car accident, had some whiplash, or got on a roller coaster, fell in the parking lot with a small fall, and then had a subdural hematoma, right? We have the classic image of subdural and epidural hematoma. I want you to look it up. One is lens shape, one is concave shape. Being able to separate that, understand, is very important. Glioblastoma multiforme, that's pretty much a brain cancer, right? It's a high-grade astrocytoma. Me being a hematology oncology fellow, I treat some of these patients. This does not look like just a simple bleed or a simple small lesion. It typically crosses over to the other side where you need contrast to really look at it. It's a high-grade malignant primary brain tumor. It's in adults, not what's happening in the situation. Wouldn't just happen a sudden, weakness in the arm. It's kind of more gradual. It's cancer. You want to understand that concept as well. Amyloid angiopathy, again, this is something that's a little more rare. If I'm going to think amyloidosis, you're going to think about more older patients. They're going to have to give you something else to kind of go to the amyloid, like kidney injury. They'll usually kind of say something about the Congo red stain, the apple green birefringence, and give you a clue to think about amyloid. I wouldn't be the first to reach that. It's pretty rare to actually cause this stroke. And ruptured berry aneurysm, again, that's the subarachnoid hemorrhage. Those are the bleeds with the sudden thunderclap headache, history of smoking, family history. Not really. And I'm going to look in the ventricles for that, right? As opposed to in the parenchyma. Little different, little presentation. In her situation, she did have a headache, but that's severe hemiparesis. And then the picture showing the bleed occurring in the parenchyma of the brain is the big clues of this one. Great job, guys. Hopefully next time, if you didn't get this right, you'd be able to get this right.
Okay, very good. Thank you, Abraham. That's really, again, that's where the learning happens. It's really important for you to not only understand how to reach the correct answer, but you need to be thinking about these other answer choices, and especially the way that Abraham talks about it. It's like, what would need to be different about this patient or this particular scenario that would lead one of those other answer choices to be right. So essentially, as you're going through questions in QMAX or your question bank, you should always kind of ask yourself, especially as you're looking at the explanations, well, okay, well, what conditions would need to be in play for this wrong answer to be the correct one? Definitely it's a way to have truly a 360 view of these concepts. Okay, we are here at the end. Question number 4 tonight. I know we got a late start tonight, and appreciate everyone hanging in there. And you guys have been doing just a phenomenal job, and love the all of the comments tonight. So let's see if we can close it off strong. And in this one, and Abraham already knows this, we don't have a slide with all of the highlights. So challenge level a little bit higher for this one. But let's go ahead and read the lead-in, since the answer choices are already covered up. Which of the following is the most likely diagnosis? Okay, so there you are. There's the probably the most typical step 1 lead in that you're going to see. So again, we're trying to kind of break this down, figure out the diagnosis for this patient. So let's read the vignette. A 54-year-old woman comes to the physician because of a 1-month history of burning pain, swelling, and weakness in her right leg. She fractured her right proximal tibia 10 weeks ago. The burning pain is constant and worsens with touch. She cannot walk more than a few steps without resting due to pain. She has a history of type 2 diabetes and hypertension. On examination, she has 1+ pitting edema extending to the mid-calf that is tender to palpation. There is erythema and warmness of the affected region on the right leg. She is unable to provide good effort on motor testing because of pain. Rubbing a cotton swab along the right foot causes severe pain. So again, the question, which of the following is the most likely diagnosis? Think about what you've seen here in this particular scenario, and think about what your differentials might be as I pass it over to Abraham.
All right. So it's okay that we don't have highlights here. You guys are all future doctors. You guys can break down the question. And again, in your mind, just highlight the word. And that's how someone asks a question. Do we highlight the words on the real exam too? I would say so. I always highlighted keywords. My goal was that if I highlight some words and I'm like, I look away for a little bit and I look back at the question, if I just read the highlighted words, I know what the question is really trying to get at and what the keywords are. So I can build the question just based on it. So if I were to highlight some of the keywords here, kind of the big things would be, 1-month history of burning pain, swelling, and, weakness in the leg. That's important. She has had a fracture 10 weeks ago. So that's kind of important here. Cannot walk without pain. That's important. Diabetes, hypertension. We always want to know history. 1+ pitting edema. There's some erythema, warmthness. So there's some something more to it than just weakness. And then even just rubbing a cotton swab on it causes severe pain. Those are real findings. And those are things that, why is this happening in a patient who just had a fracture and then 10 weeks ago? It's not like it just happened last week. Obviously, if you have a recent fracture, you're going to be a lot of pain 10 weeks ago. And then now is having all these other features that don't really fit with what's going on. So let's look at the question, look at the options. And again, we're looking at most likely diagnosis. This is your classic step 1 style question, figuring out what's going on. Option E, peripheral vascular disease. Option E, diabetic neuropathy. Option C, conversion disorder. Option B, complex regional pain syndrome. Option A, compartment syndrome. Now, like I said, the questions have been getting harder. And this is a tough one, so I don't want you guys to be too worried about it. If you guys see an option here you don't recognize, don't freak out. We're going to talk about each of these options, what they mean, and how we interpret these. But in this question, really, the fact is, the patient broke her leg, proximal tibia, 10 weeks ago, and now is having this burning, severe pain that can't really be explained by what's causing this. And even the light touch is causing severe. So let's throw out the options, and I want you guys to give your best shot. Even if you're not sure, just go ahead and shoot.
Okay, you've got your instructions. Go ahead You've got 5 diagnoses to choose from. Some or all of them could be plausible. Okay. So let's see what we got. Okay, about 39% of you went with compartment syndrome. A little over a quarter of you went with complex regional pain syndrome. Quite a few were thinking diabetic neuropathy, and a few with peripheral vascular disease. Not many went for conversion disorder. So let's go ahead and hide the results and reveal the answer. And the answer is answer choice B, complex regional pain syndrome. So a tough one. The majority didn't get it right this time, but this was the hardest question, at least in terms of p-values, amongst the 4 tonight. So regardless if you got it right or wrong, listen up as Abraham breaks this one down.
All right. Well, don't worry about this one, guys. I know it's a hard question, but and for a lot of you guys, complex regional pain syndrome might be a new term that you've never seen before. This is a testable topic. This is especially important for step 1, step 2, and step 3. And I have seen personally questions on it. So I wanted to introduce you guys to this concept early. I want you to understand what this is and really how we determine what the patient has. So let's kind of go through the other options. Let's rule out what's going on and let's try to figure out what's happening in this situation. So at least one that everybody picked was, again, conversion disorder, right? There's a psychiatric condition where there's no real pathology going on, but it's a neurological issue, right? The patient has clear edema, erythema workings. The patient can't just neurologically create that. So it's not like a pseudo disease. There's a real condition going on here. So that is right away, we got to rule it out. Peripheral vascular disease, okay, so that's not a bad thought as well. But again, typically when we think peripheral vascular disease, one leg leads to coldness, pallor, cramping, not typically associated with a fracture and like the redness or edema, pitting edema, does not fit that picture of peripheral vascular disease, right? Peripheral vascular disease, the circulation is down in one leg. That's kind of what you want to think about it. Or both legs. A diabetic neuropathy, that's a good thought. So again, bilateral numbness, paresthesia, that fits that part, but would not explain the rest of the symptoms. The edema, the severe pain with just a cotton swab touching it, not being able to walk more than a few steps. And then, there's a reason why they gave this fracture, right, this 10 weeks ago. It's not just for the fun of it, they gave a fracture. That doesn't really fit the diabetic neuropathy package. And the one that most of you guys picked, compartment syndrome. And it's a very, reasonable thought. When I have sudden acute pain in one leg, you got to think compartment syndrome, right? Compartment syndrome is the idea that the pressure is building up due to whatever it is, inflammation, bleeding, whatever it is, in the compartment of the leg, for example, and it's causing severe pain, numbness, all of what the patient has. But it would be within like a month of what's going on, or within like a few days actually of a fracture or something like that, right? This person had 10 weeks ago. How far is 10 weeks? 10 weeks is like almost 3 months. And then he's developing a lot of these symptoms. So an old fracture would not lead to compartment syndrome like this. Compartment syndrome is something that's acute, where you have increased pressures in the lower leg, then that's out of proportion to physical exam. Tense, swollen skin, you get kind of the redness and the typical stretching of the fascia that causes a lot of pain, and the severe pain due to increased pressure. But in this situation, what is complex regional pain syndrome? So it's, again, pain that's disproportionate to what should happen. So you expect someone had a fracture 10 weeks ago, they should get better by now. But you have a sudden worsening of pain. We don't really know the reason for it. It's associated with hyperalgesia, which is increased pain, erythema, edema. And then you get this like weakness that develops as well. Really, this is something that's not really well understood. Even now in 2025, we know there's some inflammation that goes on. And we know that this occurs after, a fracture or some kind of big procedure that happens. I've had patients that have had multiple chest tubes placed, and they just get this weird pain on their chest they can't explain. It just burns. And it's complex regional pain syndrome. Really, it's a neuropathic pain. That's why we're under the topic of neurology. But it is not improved by your typical, your NSAIDs or your Tylenol. It's something that's a little bit, that's why the word complex comes in, because we don't know what's going on. It's a regional pain where usually at a site of a previous injury. So 10 weeks ago, fracture, then getting unexplained pain, unexplained weakness, unexplained edema, erythema really fits the criteria of complex regional pain syndrome. We call it CRPS. That's the generic you'll see when you're on wards. But great job, guys. If you didn't get this one, compartment syndrome is also a good differential, but not the right answer because of 10 weeks of the situation. Good job, guys.
Yeah, very nice work. And again, we've got all of the QIDs that we covered here on screen, so you can screenshot it. We also have the, let me see if I can pull up the actual test. Okay, I've got the test here. I'm going to put it in the chat. So always good to not only go over some of those explanations, but you can also see, relevant bricks and videos and flash facts, especially if you've got all of the tools in the USMLE-Rx 360 Plus package.